I suspect many people on the line have shared the same experience I have, which is getting the kiddos with Duchenne's muscular dystrophy late, when all of their vertebrae are collapsed or collapsing, and they're suffering from significant back pain. Changing that natural history has been a goal of mine, but the challenge is always the data. Did we have to wait for a femur fracture? Did we have to wait for this? Did we have to wait for that? Well, I'm thrilled to tell you, primarily, I would argue, to the hard work of our speaker today, that is coming to the fore. And we hope to give you significant clinical data that will help you with your practice. So welcoming Leanne is a particular pleasure for me today. So Leanne, welcome aboard. It's grand to have you.
Thanks so much, Laura, for that kind introduction, and Michael for the invitation. It's a real pleasure to talk about this topic, which is indeed an important topic. So I'll just throw up my slides here. I really appreciate the interest, and I couldn't agree with you more, Laura. Today is all about preventing bone morbidity and Duchenne muscular dystrophy. We're moving beyond just identifying it early to prevention. So that's the real theme today. These are the funding sources for my work, and I have been a consultant too and participated in clinical trials with sponsors who are developing novel muscle and bone therapies for children with rare bone and muscle disorders, with funds to my institution, and all of the osteoporosis therapies that I'll talk about today are currently off-label in children. So I'm going to talk about the mechanisms and the manifestations of bone fragility in pediatric Duchenne, but I really want to lean into treatment today. So I will be reviewing the minimum standard of care, which is the secondary prevention of bone fragility through early identification and treatment in order to prevent progression. But at the same time, we're moving towards the prevention of first ever fractures, primary prevention in this setting. And so I'll be discussing the narrative there. And this may well be the very first disorder of childhood to launch primary prevention the world over, which is what the narrative is all about now. So for those of you who don't know, Duchenne is an X-linked recessive disorder. It's rare. Most boys are diagnosed between 4 and 6 years of age. It's due to loss of function, usually deletion mutations in the large dystrophin gene. And in the absence of treatment, in the absence of glucocorticoid therapy, there is progressive muscle strength loss, loss of ambulation by 10 years of age on average, and mean age of death, late teens and early 20s. Glucocorticoids are the standard of care for the treatment of Duchenne. They have shown consistent benefits in clinical trials. They prolong ambulation by 3 years. So boys will walk typically until they're about 13 on average if they take glucocorticoids in a timely fashion. Scoliosis is significantly decreased on glucocorticoid therapy. They improve cardiorespiratory function, which provides rationale for their use beyond loss of ambulation. And they prolong life expectancy to the mid to late 20s and even into the early 30s now, along with improved respiratory and cardiac care. But they have harsh side effects. So notionally, you'd like to start therapy as early as possible in such a progressive disease, but there's double the risk of fractures, for example, if you start before 5 years of age. Now, there are a number of different glucocorticoid regimens that are used. These are 3 of the most common: daily prednisone, daily deflazacort, and intermittent prednisone, 10 days on, 10 days off. There's also weekend-only prednisone and twice-weekly prednisone that is used in this condition. I'll be talking mostly about these 3 more common regimens. They're all high dose, and they're all prescribed in the spirit of long-term use. At the same time, Duchenne is one of the most intensely studied conditions in contemporary times in terms of cure, rescue of the phenotype, dystrophin restoration through genetic and cell-based therapies and muscle biology targeted therapies. So lots of trials going on at the moment targeting the underlying disease. There's been some exon skipping drugs that have been approved by health authorities, for example, and I encourage you to listen in to a speaker talking about treatment of the underlying disease, because this is an area that's got tremendous momentum behind it. But I'm focused on the bones today. Now, I really want to talk about treatment. So I thought about just showing you this slide, just saying the bones are bad in this situation and leaving it at that. And then I thought, no, I really should show you some x-rays because we're all boneheads after all. And so this is on the left, a 10-year-old boy, 2 years after starting steroids, and he has a devastating femur fracture that takes him off his feet permanently. And then on the right, this is a different boy who was on steroids for 7 years. Nobody was monitoring the spine, and he presented with full vertebral collapse. And this is very difficult to treat once it's settled in like this. We know that the muscle weakness drives the long bone and other non-vertebral fractures, and that steroids potentiate the long bone fracture risk. We know that vertebral fractures are relatively uncommon in the absence of steroids. And so really it is the steroids that are driving the vertebral fracture phenotype for the most part. These are some sound bites with respect to the natural history of bone morbidity in Duchenne. Long bone fractures occur in up to 60% of boys in the literature. Glucocorticoids double the long bone fracture risk. Low trauma long bone fractures have been reported prior to diagnosis, so even in toddlers with Duchenne. Femur, tibia, and humerus fractures are the most common long bone fractures. So not only do we have a high fracture frequency, but we have an abnormal fracture distribution. Usually in the typical setting, it's forearm fractures in otherwise healthy children. Here we have femur fractures being the #1 long bone fracture. And antecedent long bone fractures predict prevalent vertebral fractures 4.5 years following steroid initiation. Long bone fractures have been associated with permanent premature loss of ambulation, as I said. So if you expect to walk on your steroids till you're about 13 or so, and you have a femur fracture at 8 and you come off your feet permanently, that is devastating for families. So even a single low trauma long bone fracture merits a diagnosis of osteoporosis in this setting and initiation of bisphosphonate therapy. You do not need 2 or more fractures by 10 or 3 or more long bone fractures by 19 years of age. That was ISCD criteria targeting otherwise healthy children where we didn't want to overdiagnose osteoporosis. In the high-risk setting, the definition is very different. The frequency of vertebral fractures is low in the absence of glucocorticoid therapy, although not absent. We've shown that it's less than 3% in boys 4 to 8 years of age. Vertebral fractures can occur as early as 6 months following steroid initiation, and up to 75% of boys with steroid-treated Duchenne are anticipated to have vertebral fractures by 8 or more years of steroid therapy. And the predictors of vertebral fractures are all signs of systemic glucocorticoid exposure, including low lumbar spine volumetric BMD Z-score, low height, increases in weight Z-score, increases in glucocorticoid duration and dose, and increases in bone age delays. We've recently published a paper that shows that bone age delay is a very sensitive marker of steroid exposure and the increased risk of prevalent vertebral fractures. Now, vertebral fractures are typically asymptomatic in their early phases, but they can lead to progressive collapse and debilitating back pain if not treated and identified in a timely fashion. And that's called the vertebral fracture cascade, and I'll show you a picture of that in a moment. There are no reports of spontaneous vertebral body reshaping. That is, there are no reports of restoration of vertebral dimensions following vertebral fractures in Duchenne in the absence of bone protection therapy. So why are fracture rates so high in Duchenne muscular dystrophy? Well, DMD is a perfect storm for bone fragility. There's Duchenne-related risk factors, that progressive myopathy, loss of ambulation, frequent falls as the boys struggle with their ambulation. The steroid doses are very high and prolonged, as I said earlier, and steroids cause delayed puberty. This is virtually universal in my experience, and growth deceleration as well as growth arrest. And this growth curve that you see here for height is not exceptional. This is the norm. Now, this is what the bones look like, the long bones. You can see that there's been lack of periosteal apposition because of lack of weight bearing and muscle tug on bones, also lack of muscle bone cytokine communication. And so the cross-sectional diameter of the femur is reduced, and that's an independent risk factor for fracture. You can also see the bone density is low, and there's a little crack there in the distal femur. Now, this is a very elegant paper by Nicola Crabtree, where she shows that there's dramatic loss in bone density when the boys come off their feet. And that makes sense, of course, but she represents it very nicely pictorially. So if you just track to 2 years, you can see that after 2 years of follow-up, the healthy boy has nice trabecular volumetric BMD at the 4% site of the tibia and the fibula close to the distal growth plate. And then the boy with Duchenne who remained mobile, he has more trabecular volumetric BMD than the boy who lost ambulation over that 2-year period of observation. So a profound loss in VBMD of the distal tibia and fibula here in this non-ambulatory boy. So we don't like long bone fractures because they take the boys off their feet prematurely. We also don't like them because of the fat embolism syndrome. So what is the fat embolism syndrome? In Duchenne, where there's steroids on board and loss of ambulation, there's an accumulation of adipocytes in the marrow of the long bones, and we see that under the microscope. And then at the time of a fracture, or even just at the time of a bone bruise or bone injury, I've seen this happen in a patient, or heard about it at least, who just gently knocked his arm against the wall when he was going around a corner in his wheelchair, and he developed FES. What happens is at the time of bone injury, the adipocytes are released into the circulation. They form fat globules and they shower the lungs and cross the blood-brain barrier and cause respiratory distress and neurological deterioration. So if you have a boy who had a trivial or major accident and then deteriorates within hours to even days afterwards, this is FES till proven otherwise, and this has been linked to death. Laura McAdam out of Toronto has described 5 deaths due to FES, 4 of which were confirmed on autopsy. This requires medical attention urgently, intensive care. You can see the fat emboli on the retina, and they need stress steroid dosing. So I emphasize this because knowing about this can save lives. Now, this is a boy who had a fracture of the tibia at 6 years of age. And when boys have fractures, you try not to immobilize them or cast them if you can get away with it, because you want to keep them walking. You have to cast. But in any case, he had fracture management. I didn't see him. He came back to my clinic 7 years later, was referred, and had tremendous back pain, and his spine is fully collapsed. So we now know his first osteoporotic event was at 6 years of age. Now, vertebral fractures are so important as a manifestation of bone fragility in children, including in steroid-induced osteoporosis, that they require standardized reporting. And we have validated through the Canadian STOP study the Jeanette semi-quantitative method to define a vertebral fracture in children. And the GSQ defines a fracture of the vertebral body critically as more than 20% loss in vertebral height ratio. And then there are degrees of severity depending on the degree of vertebral height ratio loss. Now, in a very aggressive osteoporotic condition like Duchenne, if you have a boy who at time point 8 has vertebral dimensions that are 100%, there's no loss of height at all, and over time he loses to 16, 17, 18%, I would be very sympathetic to you calling that a fracture in evolution. And many of us are thinking about those kinds of declines in that way these days. Now, this is the vertebral fracture cascade. This is a boy at 8 years of age on steroids. I start to monitor him. It's a beautiful spine. He comes back a year later for routine spine imaging. He has a grade 1 vertebral fracture. Looks trivial, but it is not. He was not treated at the time because this was many years ago when we didn't know what we were doing, and those fractures just progressed. The T9 got worse, and then there's new fractures adjacent. So this is the vertebral fracture cascade, where fractures at time point A predict new fractures at subsequent time points in children with persistent risk factors for fractures. And this is a slide that shows the very clear relationship between glucocorticoid duration and the probability of any clinical fracture, whether it's a non-vertebral fracture or a symptomatic vertebral fracture. If you look closely, you can see that little latent period right at the beginning, about 6 months, and then the fractures start to emerge after starting steroids. So as Laura said at the beginning, we have to get to these boys as early as possible. Now, in children who have transient threats to bone health, like leukemia, they have the potential to reshape vertebral bodies after vertebral fractures if their threat to bone health is withdrawn. We have never seen spontaneous, that is medication unassisted vertebral body reshaping of fractured vertebrae in Duchenne because the boys don't grow well, and that's a growth mediated phenomenon. The steroids are prescribed for long-term use. The myopathy is progressive, and that vertebral fracture cascade is like a train accelerating out of the station. Now, I want to sensitize you to the fact that we certainly like to do lumbar spine BMDs as pediatricians, and I certainly support that. The lumbar spine BMD tends to hang on longer. The hip BMD Z-score just declines typically from the moment I meet the boy. And so the hip BMD is a very sensitive clinical site, and I use that as a marker of the extent to which the myopathy is impacting bone density. So that's the background information for you. I'd like now to talk about the current minimum standard of care, also known as the care considerations, which were published in the Lancet Neurology in 2018. So what do we mean by minimum standard of care? This is the standard of care that we want to see boys with Duchenne receive the world over, wherever they are. These are standards of care that can be printed off and taken to healthcare administrators to advocate for a minimum standard of care in a given center. And then, of course, you can do more than the standard of care, but this is the minimum. We certainly recommend optimizing conservative measures to enhance bone health, like identifying nutritional deficiencies. Remember that steroids increase catabolism of 25 vitamin D, so you'll frequently see low 25 hydroxy vitamin D levels and need higher doses of vitamin D than you might expect. We diagnose and treat delayed puberty. I start to talk to boys about delayed puberty due to steroids around 12 years of age and sort of gauge their sensitivity to talking about that. And then we try to initiate therapy by 14 if they haven't started puberty on their own. Some boys aren't ready at 14, but we certainly get the conversation going so they know that's available to them. We diagnose and treat over and underweight, try to prevent overweight, because once the weight's on, it's difficult to get off. And we talk a lot about fall prevention, especially in Canada with all the ice that we have, and not just in the boys who are ambulatory, but in the boys in the wheelchairs. I've seen so many accidents with wheelchairs, and I also talk about fall prevention in the caregivers. And I've certainly seen caregivers who have fractured who then struggle to care for their child. Recombinant human growth hormone, or IGF-1, is not routine. We simply don't have sufficient safety and efficacy data over a long enough term to support that as routine, but there's some nice studies that have been done by Milan Ritter in the United States that suggest that these may help growth in the short term, but we need a little bit more information to really understand the impact of that overall on the boy's health. So I think of testosterone therapy as adjuvant. It is a weaker modifier of skeletal strength. It certainly does not prevent or rein in the osteoporotic phenotype, but it is part of the care considerations. We really, though, do need those heavy hitters. So we're going to be going through the different osteoporosis agents. Anti-sclerostin antibody is theoretical in Duchenne, but the other agents have all been used, and I'll be talking about those now. I want to tell you about the way in which the minimum standard of care has shifted over the years. The care considerations were first developed in 2010 in collaboration with the Centers for Disease Control in the United States. And they said that if you had back pain or kyphosis, you should have a spine x-ray and then use IV bisphosphonate therapy if you had vertebral fractures. That was the care guideline. And you're probably thinking, well, that sounds lean compared to what we do. And of course it is lean, but that was what was recommended based on the evidence at the time. And then between 2010 and 2018, we learned that vertebral fractures are a key hallmark of glucocorticoid toxicity, that they're frequently asymptomatic in their early phases, that more than 20% loss in vertebral height ratio was a valid benchmark for a vertebral fracture, that they progress in the absence of treatment, and that if we treat early, we can prevent that progression. So In 2018, when the guidelines were rewritten, we recommended monitoring from the time of diagnosis or no later than the time of steroid initiation with periodic spine radiographs and bone density studies to treat early signs of vertebral collapse with IV bisphosphonate therapy, and as a minimum to treat first long bone fractures with IV bisphosphonate therapy, and not to wait till you had multiple long bone fractures. Now, if you're on the call today and you're just starting to mobilize your resources to reach the minimum standard of care, then this is the most important slide for you today as part of this presentation. So here's what I just said, but sort of graphically represented. So we recommend bone density testing annually, starting around the time of diagnosis and no later than steroid initiation. We recommend multi-site BMD, spine, hip, and total body, recognizing you can't do hip until boys are a little bit older, 5 or 6 years of age. If a boy is on steroids, you do spine imaging by DEXA or X-ray every 1 to 2 years. If they're not on steroids, spine imaging is every 2 to 3 years, and you do spine imaging more often if bone density drops by more than half a standard deviation or if there's back pain. And then you look for very early signs of osteoporosis, including those early vertebral body changes, which look trivial, but they're not, or if there's a first long bone fracture. And you start intravenous bisphosphonate therapy at that time, and you continue bone protection for as long as the child or man is on steroid therapy, and maybe even longer if there's continuous bone deficits like low BMD, vertebral fractures, long bone fractures. So why did we recommend IV bisphosphonate therapy instead of oral bisphosphonate therapy? Well, we have shown many years ago when I was at the Shriners working with Francis Glorieux that the bioavailability of oral alendronate is very low, less than 1%. And IV bisphosphonates are just more potent than oral agents. This is an aggressive osteoporosis, so it needs to be met with an aggressive treatment. And IV bisphosphonates are the most frequently used agents to treat osteoporosis in children. So that's why we recommended IV bisphosphonates as part of those care considerations. Since the care considerations were published in 2018, there's been even more evidence developed to support the use of IV zolodronic acid in pediatric Duchenne. These are two very important trials. They're both randomized controlled trials, which is very rare in the pediatric osteoporosis space in general, let alone in Duchenne. Both trials were secondary prevention trials because they both included patients with vertebral fractures at baseline. The Zachrin and Munz paper, all of the patients had DMD. A third of them enrolled patients with baseline vertebral fractures. In the Ward and Munz paper, 38% were diagnosed with Duchenne. The others had nephrotic syndrome and rheumatic disorders, all steroid treated, and all patients had baseline vertebral fractures. Both studies met their primary outcome, which was significant increases in lumbar spine BMD Z scores on IV zolodronic acid versus calcium and vitamin D alone, or IV zolodronic acid versus IV placebo. I want to tell you about these trials because I think they're really important. So this is the first trial, which is IV zolodronic acid versus IV placebo in children with steroid-treated disorders, a third of whom had Duchenne muscular dystrophy. So the enrollment criteria on the left was that they had to have at least 1 dose of glucocorticoid for the treatment of their underlying disease in the 12 months preceding enrollment. All had vertebral fractures at baseline, as I said, plus a lumbar spine BMD-Z score of minus 0.5 or worse, and patients were randomized 1-to-1 to IV placebo or IV zolodronic acid. We recruited a total of 34 patients. The target was actually closer to 80, but it's hard to recruit to IV placebo trials. The dose of zolodronic acid was 0.05 milligram per kilogram at baseline and at 6 months, with an end of study visit at 12 months. And so even the first dose was a full dose of 0.05 mg per kilogram. The primary outcome was the difference in the change in height Z-score adjusted lumbar spine BMD Z-score. And as you can see here, the difference in the change was big and significant. It was a difference of 0.75 standard deviations, 3/4 of a standard deviation with a significant p-value. Now, this result favoring zolodronic acid is interesting because 61% in the zolodronic acid group received steroids during the trial compared to 25% on placebo. There were no patients on zolodronic acid who had new low trauma vertebral fractures at 12 months. 2 patients on placebo had a single incident vertebral fracture each, one of whom withdrew from the study because the vertebral fracture was painful. Now, this is the Zakarin and Munns paper that was out of Australia. The study I just showed you was international. This is out of Australia. And all of the patients had Duchenne, as I said. The enrollment criteria on the left were a lumbar spine BMD-Z score of -1 or worse, and patients were randomized 1-to-1 to IV zolodronic acid plus calcium and vitamin D versus calcium and vitamin D alone. 30% had vertebral fractures at baseline, but only grade 1 and 2. You couldn't get in the trial if you had a grade 3 fracture. And what you can see here is that zolodronic acid increased lumbar spine BMD-Z scores relative to calcium and vitamin D alone. And the difference in the change was plus 1.3 standard deviations over 2 years in this case. Most of the gain, though, as you can see here in the left graph, was in the first 12 months. Now, this is the fracture data from the Zakarin and Munns Duchenne specific trial. At the spine, I think this is very interesting. So 32% of the control population had prevalent vertebral fractures at baseline, 26% in the intervention group, all grade 1 and 2. And then over 24 months, 24% in the control group had new vertebral fractures compared to 15% in the intervention group. 5 patients in the control group withdrew from the study because of incident grade 3 fractures. None of the patients on zolodronic acid had incident grade 3 fractures, and there was 1 long bone fracture in each group, the humerus in the control group and the tibia in the intervention group. So descriptively, incident vertebral fractures were less frequent and less severe in the intervention group, but we still saw vertebral fracture progression in this cohort, a subset of whom had fractures at baseline. So that's IV zolodronic acid. Some centers use IV pamidronate, which is also an effective agent. What about oral bisphosphonates, alendronate and risedronate, for example? Well, this is a study out of Brenda Wong's group. Shui Shatian has looked at the changes in lumbar spine BMD-Z scores and total body BMD-Z scores on alendronate. This is an uncontrolled study looking at the change in BMD pre-treatment versus post-treatment in 54 steroid-treated boys with Duchenne muscular dystrophy. And Dr. Wong recently told us about her rationale for using oral bisphosphonate. She said that many years ago, when she was thinking about the importance of bone protection, she spoke with her adult colleagues who, of course, recommended oral bisphosphonates because that's what adults do. So that makes a lot of sense how that all came about. And what she shows very nicely is that lumbar spine BMD-Z scores decline pre-treatment, and then the slope of the curve changes, improves on alendronate. And that improvement at the spine lasts about 3 years, and then it starts to decline again. But total body BMD-Z scores, whether height corrected or not, do not improve on oral alendronate. And that just speaks to the aggressivity of the myopathy and the steroids combined. 35% of patients had new or worsening vertebral fractures. So how do we put this all together? So I've been working on a systematic review of bisphosphonate therapy in patients with steroid-treated Duchenne with Eric Landfeld out of Sweden. And we just show you the mean annual change in lumbar spine aerial BMD-Z scores in patients with steroid-treated Duchenne who received oral or IV bisphosphonate therapy and where the studies enrolled more than 20 patients. So there's a study by Srinivasan out of the UK that looked at risedronate, and you can see that the mean annual change was in a negative direction. And then Shui Shatian's study I just told you about, you can see there was a slightly positive mean annual change, but the biggest impact on spine aerial BMD-Z score was by the Zakarin and Munns IV zolodronic acid plus vitamin D trial. So I think this really consolidates that in the setting of an aggressive osteoporosis, we probably need to be using a more potent bisphosphonate, i.e. IV. Now, this is a study by Nat Nazamiat, who's quite active in the field of bone health and Duchenne, doing some lovely work. And he looks at the change in vertebral morphometry semi-quantitatively, so based on Genant grades, on oral alendronate in steroid-treated Duchenne after 3 to 5 years of oral alendronate. And you can just see, just sort of looking at this generally, that most of the vertebral fractures that were present at baseline stabilized in blue on oral alendronate, and some of them actually improved their vertebral dimensions, and then some of them got worse. So a little bit of a mix here. So I've spent a lot of time thinking about why we see such progressive vertebral collapse, certainly in the untreated state, no question, but even on IV and oral bisphosphonate therapy. Is it because the osteoporosis is just so aggressive that we just can't override that with anti-resorptive drugs with that mechanism of action? Is it because they don't grow well, so we don't get the synergistic effect of IV bisphosphonates plus growth on bone? Or is there a relationship with abnormal spine biomechanics? I spent a lot of time working with orthopedic surgeons, and these are a lovely group of people. And if you work with them enough, you start to think like them. So I just want to tell you a little bit about what we've learned about spine biomechanics and vertebral fractures. In the ambulatory phase, boys with Duchenne have hyperlordosis. You will know this when you see these boys. They stick out their bums and put forward their chests, and that's because of the primary proximal myopathy. And we've even seen spondylolisthesis and spondylolysis in this setting with the hyperlordosis. This is a lovely study by Dr. Kim Fung, who's a fellow working with us, just published actually a couple of weeks ago. And we tested out this theory that perhaps we were seeing more lumbar fractures in Duchenne because of that hyperlordosis. So we took a cohort of boys with Duchenne in blue on the top right, and we plotted their vertebral fracture distribution relative to the vertebral fracture distribution of steroid-treated children with leukemia, rheumatic disorders, and nephrotic syndrome. And we did see that proportionately there were more lumbar fractures compared to thoracic fractures in the boys with Duchenne muscular dystrophy. And then we plotted them, and we call this the spinunculus, which is a neat term to describe the distribution of vertebral fractures. And the sagittal bar represents the frequency of vertebral fractures at each vertebral level. And you can see that indeed in the ambulatory phase, descriptively, we get the sense that there are more lumbar fractures compared to when the boys are non-ambulatory. They lose their hyperlordosis because they develop hip contractures from prolonged sitting. So I think that this hints that we may be seeing a relationship between spine biomechanics and vertebral fractures, and that might be contributing to why we see vertebral fractures progress in this situation. And before I leave bisphosphonates, I just want to say that this was a great study, retrospective, but on a large number of boys, looking at predictors of longevity over decades. And this is out of Nova Scotia by Kevin Gordon and crew, and he showed that 60% of boys treated with a bisphosphonate were alive at 24 years. This is back in the day, and 60% of boys not treated with a bisphosphonate were alive at 16 years. So this suggests that bisphosphonates may even contribute to longevity. And when you think about why that might be, is it that we are preserving the heights of the vertebral bodies as far as possible and maximizing pulmonary function test results? So that's been described in adult PMO, that patients with vertebral fractures have reduced pulmonary function testing. Is it because we're maintaining the integrity of the long bones to a greater extent and preventing those kinds of cracks that lead to fat embolism syndrome? We don't know, but I find this very interesting. And steroids in this paper were also predictive of longevity, which was good to see. So let's now start thinking beyond bisphosphonate therapy for Duchenne. I want to talk about Denosumab, we'll talk about anabolic therapy, we'll talk about what the neurologists are doing in terms of the impact of different steroid regimens on bone, and we'll talk about the novel dissociative steroid called vamorolone. So Denosumab, first of all, I'm going to tell you about a trial that I have done, pilot, tiny numbers, but nevertheless interesting, looking at Denosumab versus IV Zolodronic acid in steroid-treated Duchenne. And what got me thinking about this was the high frequency of adverse events with first and even subsequent infusions of IV bisphosphonates in steroid-treated Duchenne, as well as other conditions. This is from our randomized trial of IV Zol versus IV placebo. You can see frequent side effects with the first infusion. Even 25% of the placebo group, however, had side effects with the first infusion, which is a good reminder that some of those side effects in the chronic illness setting could be due to the underlying disease and not due to drug at all. And then side effects were less common within the first 10 days of the second dose. Most common side effects were gastrointestinal. And remember, there were some children with Crohn's disease in this trial, and that might contribute to why we saw so much GI side effects. And then arthralgias, myalgias, and bone pain, fever, and hypocalcemia was less common than some of the other side effects. So I think we're all familiar with these side effects, those of us who prescribe IV bisphosphonates, and I submit to you that they are worse in patients with chronic illness and can be particularly severe in Duchenne muscular dystrophy. We have seen the first infusion side effects of zolodronic acid precipitate adrenal insufficiency in boys with Duchenne muscular dystrophy. I give hydrocortisone on the day of the infusion and for 72 hours afterwards. Rhabdomyolysis has also been described after the first infusion of Zol in Duchenne, and peri-infusion hydration is probably important to prevent that. And otherwise, we give them supportive care, and we're on a pager to support them through any difficulties they might be having. But we sat back and thought, is there a way that we can still provide effective anti-resorptive therapy, but with a more convenient route of administration and fewer side effects than IV Zol? And so we thought of Denosumab, a fully human monoclonal antibody to rank ligand, a potent anti-resorptive, given sub-Q every 6 months, so more convenient than IV, with favorable first exposure tolerability in adult trials. So this was of interest to us. Denosumab, of course, is an antibody to rank ligand that binds to rank ligand, so it cannot bind to its receptor on osteoclast precursors. So osteoclast differentiation, proliferation, and survival is inhibited. Denosumab is approved for postmenopausal osteoporosis, for adult steroid-induced osteoporosis, and adult male osteoporosis. So there's a lot of experience with Denosumab in adults, including in the adult GIO context. But even beyond the improved convenience and also the improved first exposure tolerability, I was interested in Denosumab for the following reason. Rank ligand is an osteokine, and it has been shown to negatively impact muscle in Duchenne because it's part of the inflammatory cascade, NF-kappa B. And this is proof of principle of that. This is a lovely study by Jerome Frenet out of Laval University, and he gave anti-rank ligand antibody to the MDX mouse at increasing doses. And he showed that on high dose anti-rank ligand antibody on the far right, that there was an improvement in the extensor digitorum longus muscle of the MDX mouse relative to low dose anti-rank ligand antibody. He also showed there was less muscle damage and also that there was improvement in CK activity. Now, of course, we're all worried about the rebound phenomenon with Denosumab, which has been described in 2 settings in children. First, in children with high bone turnover states like osteogenesis imperfecta, fibrous dysplasia of bone, and juvenile Paget's disease. And it's been described in children receiving extremely high doses for giant cell tumors of bone and aneurysmal bone cysts. The rebound phenomenon is when the drug ostensibly wears off, the osteoclasts come back with a vengeance, they resorb bone, and that liberates calcium and can cause life-threatening hypercalcemia, and that's been described in these settings that I have mentioned. So I was very cognizant of that when I was thinking about this trial, but I hypothesized we would not see the rebound phenomenon because of the low bone turnover that's characteristic of Duchenne. And we did a study looking at bone turnover on trabecular surfaces by bone histomorphometry in Duchenne, collaborating with the Shriners Hospital in Montreal and the Vienna group. And we showed that the bone formation rate is 3/4 of the healthy average, even before you give intravenous bisphosphonate therapy. So I felt that it was reasonable to explore this in the context of a Health Canada registered trial under careful observation and informed consent. So we aim to acquire pilot data over 2 years about the feasibility and safety and efficacy of Denosumab versus the current standard of care for the treatment of osteoporosis in Duchenne IV zolodronic acid. And the trial is registered on clinicaltrials.gov. Boys were enrolled if they were 4 to 16. They needed to have a confirmed diagnosis of DMD and at least one low trauma vertebral or long bone fracture. We had a long list of exclusion criteria. I'm not going to go through those in the interest of time, but just to say we really wanted to carefully select who would be enrolled in the trial, and Health Canada also reviewed this and had suggestions for us to also add some exclusion criteria. We randomized boys 1-to-1 to Denosumab 1 milligram per kilogram or IV zolodronic acid 0.025 milligram per kilogram. Boys were dosed every 6 months with an exit visit at 24 months. We did a 48-hour post-dose ionized calcium. We did tibia, PQCT, DEX at the spine and the hip, and serum bone turnover markers every 6 months, and a renal ultrasound and lateral spine x-ray every year. These are the baseline demographic and clinical characteristics. Now, there's only 4 patients in each group. So this was a tiny study limited by funding, but we wanted to start somewhere, and we wanted to have a high quality study design so that we could learn as much as possible from these 8 boys. The main difference at baseline was that in the zolodronic acid group, they had a little bit less steroid exposure, and they were a little younger at diagnosis. So here are exploratory efficacy outcomes. No p-values, too small, too descriptive for that. But on the left, you can see the cross-sectional means at each time point, and on the right, the difference in the change. So they started out similarly for lumbar spine aerial BMD Z-score by DEXA, and they both went up on Denosumab and zolodronic acid, and on zolodronic acid were a little bit higher at the end of the 24 months, cross-sectionally. But when we looked at the difference in the change, the difference in the chain was similar. And then there's the total hip aerial BMD Z-score. You can see that in the zolodronic acid group, they started out lower and they end up similarly cross-sectionally at the 24-month mark. And the difference in the change is on the right, a little bit of a increased change on IV zolodronic acid. This is the distal tibia trabecular volumetric BMD by PQCT. So they started out similarly at baseline on the left, and then at 24 months in the left montage, a little bit of an increase to a greater extent on zolodronic acid, and the difference in the change reflects that same phenomenon. Here's the vertebral fracture data. The zolodronic acid group, despite having less steroid exposure, interestingly had more vertebral fractures. And so 2.6 for an SDI at baseline in Zol compared to 1 on Denosumab. This is the sum of the Jeanette grades. The SDI reflects vertebral fracture number and severity. And then in both groups, the SDI decreased on the 24-month X-ray. Here's the pain profile. I just did it by patient because there's so few patients. So on Zol, baseline to 24 months, we see 8 to 2, 2 to 0, 0 to 0, and 6 to 2. And on Denosumab on a 10-point scale, 8 to 0, 8 to 0, 4 to 0, and 0 to 0. So good pain relief with both agents. Now, here's what I think is the most important slide of this tiny pilot study. And this is zolodronic acid versus Denosumab, 4 patients in each group. 4 on zolodronic acid had at least 1 adverse event compared to 3 on Denosumab. There were 51 adverse events recorded on zolodronic acid over 2 years compared to 17 on Denosumab. 17 AEs were deemed related to zolodronic acid, and 1 AE was deemed related to Denosumab, and that was a mild transient injection site reaction. So adverse events were far less frequent on Denosumab, which was what we had hypothesized and why we went forward with the trial in the first place. And then just a couple of high points on this slide. You can see that in the zolodronic acid group, the number of patients with symptoms first with adverse events following each dose decreases with subsequent dosing. So 4 patients had side effects after the first dose, and then 3 on Zol after the second dose, and 2 on Zol after the third dose. We can see that hypocalcemia occurred in all 4 patients on Zol, asymptomatic, but did not occur on Denosumab. Here's the bone turnover markers. The bone turnover markers did not increase. So we did not see the rebound phenomenon in terms of increases in CTX or bone-specific alk phos, and we did not see any episodes of hypercalcemia, and there were no events of nephrocalcinosis on Denosumab either. So Denosumab 1 milligram per kilogram every 6 months was logistically feasible, well tolerated, and safe in 4 boys with Duchenne over 2 years. None of the boys withdrew from the study. Drug-related AEs were far more common on zolodronic acid, which confirmed our a priori hypothesis that Denosumab would be both practical and well tolerated. The rebound phenomenon was not observed, and exploratory efficacy outcomes were sufficiently favorable on Denosumab that this now warrants further investigation for the prevention and treatment of osteoporosis in Duchenne. So we have a lot of questions. This is the do not try this at home slide. I think we have to understand a lot more before this gets rolled out in any clinic as part of any standard of care. We don't know what the long-term effect of Denosumab will be on bone health relative to zolodronic acid. We don't know if the rebound phenomenon will emerge with missed or delayed Denosumab dosing, with puberty, on vamorolone, which has normal bone turnover, as you're going to see in a moment, or on dystrophin restoration therapy. And we don't know if we need to seal in any BMD gains that we see on Denosumab with a longer acting anti-resorptive near the end of therapy. So let's move on now to finish up talking about anabolics and tweaking of the therapy for the underlying disease. So know that anti-resorptives are most effective at the spine because the spine is trabecular, it's porous, and there's an increased surface volume that can be filled up by BMD altering medications. Cortical bone is compact, there's not as many holes, and so there's less surface area on which BMD can act. And anti-resorptives do nothing to change bone geometry and make those bones bigger. So here's where we think about anabolics, and this is another study by Nat Nazamyant, and he looked at teriparatide in boys and men with Duchenne 13.9 to 22.1 years of age, and he looked at their vertebral fractures and saw that 31% improved, 29% were stable, but 21% were worse. My concern with teriparatide is that although it may be effective at the spine relatively, and that's what we see in adult postmenopausal osteoporosis mapped out here, it is not as effective as zolodronic acid and Denosumab at the hip, and yet the hip really plummets in Duchenne. And you can see that anti-sclerostin antibody and that followed by Denosumab is a more powerful combination at the spine and at the hip. Certainly, anti-sclerostin antibody is very attractive in this setting, as sclerostin inhibits bone formation. Bone turnover is low in Duchenne muscular dystrophy. I would love to use an agent that releases the inhibition on bone formation like anti-sclerostin antibody. This has not been done. It's theoretical, but this is an unmet need. This is a beautiful study by Mike Ominski that shows in the rat the effect of increasing doses of anti-sclerostin antibody on bone density at the top and then bone structure at the proximal femur and at the femoral shaft. So we're seeing not only an increase in bone density, but improved bone cross-sectional diameter and cortical thickness. So certainly prevention of first fractures is at the foremost of our minds as we go forward. Studies to determine now the best agent for prevention of first fractures starting before a first ever fracture, and standardization of outcomes across studies so that comparisons can be made ultimately are essential. And this is the narrative that's on the table now among those of us working in this area. I'll finish up now by talking about the first principle of chronic disease osteoporosis management, and that is effective treatment of the underlying disease with as steroid-sparing an agent as possible. So the neurologists have looked at the effect of their different steroid regimens on bone. This is a lovely study by Jared Wong's group, where he shows that daily deflazacort has the greatest likelihood of a fracture, followed by daily prednisolone, and then intermittent prednisolone and deflazacort are relatively bone sparing, and steroid naivete is the most bone sparing of all. And then Nicola Crabtree, in a convenient sample of 50 boys from 2 UK centers, looked at the daily prednisone relationship with prevalent vertebral fractures, as well as the intermittent 10 days on, 10 days off relationship. She shows that daily prednisone is linked to patients 40% of the time after 4 years of steroid therapy having prevalent vertebral fractures, compared to 8% on intermittent prednisone at 4 years. So you can protect the bones by giving intermittent steroids, but if you read the paper, it comes at a cost to muscle strength. And this is a really important paper that was a long time in the works, the 4 DMD study comparing for muscle function the 3 different steroid regimens, daily pred, daily deflaz, and intermittent pred, in a randomized double-blind placebo-controlled trial. And they showed, not surprisingly, that intermittent prednisone held on for a bit in terms of muscle function. This is the time to rise from the floor, but ultimately intermittent prednisone was inferior in maintaining muscle strength relative to daily prednisone and daily deflazacort. And that corroborated Nicola Crabtree's observations on that convenience sample of 50 boys. So you can give less steroids, bones will be better, but it'll be at a cost to muscle strength. And that's a challenging situation for families. So is there a steroid that can effectively treat the underlying myopathy, but with less of a deleterious effect on skeletal health, including bone metabolism, growth, and bone strength? This is my final chapter in this presentation. So there is one such steroid that is under study. It is not approved by any health authority around the world. It's still in clinical trial development. It's called vamorolone, or VBP15. It is a dissociative steroid targeting muscle and favorably bone in steroid-treated Duchenne. So vamorolone is distinct from the corticosteroid class. It lacks an 11-beta oxygen. So through conformational chemistry, it differs slightly from prednisolone and deflazacort, and thereby interacts with its receptor differently. It is not a substrate for 11-beta hydroxysteroid dehydrogenase enzymes, which are what mediate the bone phenotype on classic steroids. It retains its trans-repression activity, which mediates the anti-inflammatory effect, but it has reduced trans-activation activity. It's also antagonistic to the mineralocorticoid receptor, which is interesting to think about in terms of cardioprotective properties, although that's unproven. The preclinical studies were encouraging. VBP15 treated mice were longer than prednisone treated mice, and the trabecular thickness at the femur was better than prednisone. This is the pivotal trial. It's called Vision DMD, or the 004 study, as we call it. This was a randomized double-blind placebo-controlled trial of placebo versus prednisone at standard dosing versus vamorolone 6 milligram per kilogram versus vamorolone 2 milligram per kilogram, which were vetted in dose-finding studies. That was for 24 weeks, and then there was a 4-week transition period as boys on placebo and prednisone transitioned to vamorolone 2 or 6 milligram per kilogram. That was another 20-week period, and then the boys went on expanded access, and dose adjustments were permitted at the discretion of the physician at that point in time. These data are published, and the study met its primary outcome, which was the difference in the change on vamorolone 2 and 6 milligram per kilogram relative to placebo. So you can see that for a number of muscle function outcomes, vamorolone 2 and 6 mg per kg were superior to placebo over a 24-week period. Now, this was an exploratory outcome looking at the efficacy of vamorolone relative to prednisone. This is a post-hoc exploratory outcome over 24 weeks. And you can see, if you look at turquoise compared to green, vamorolone 2 compared to green prednisone, that vamorolone 2 milligram per kilogram was not as efficacious as prednisone, whereas vamorolone 6 milligram per kilogram was as efficacious as prednisone over 24 weeks for the muscle function outcomes. And then when you look at the trajectory for muscle function outcomes like time to stand velocity and the 6-minute walk distance on VAM2 in hatched red and VAM6 in solid red compared to placebo, and then on their own, you can see that the VAM2 effect starts to wane beyond 24 weeks, but the VAM6 effect, the positive effect, hangs on. So VAM2 shows less efficacy over 48 weeks, and VAM2 also shows less adrenal suppression than VAM6 milligram per kilo per day, which does suppress the adrenals. This is showing VAM6 compared to prednisone and deflazacort, where prednisone and deflazacort cohorts were external comparators from the 4 DMD study, and you can see VAM6 is comparable to prednisone and deflazacort over 48 weeks. In both timed muscle function outcomes. Mood seems better on vamorolone, so behavioral problems were reported on prednisone 32% of the time, on VAM6 21% of the time, and on VAM2 almost 17% of the time, and on placebo almost 14% of the time. And finally, what about skeletal health? So in terms of bone biomarkers and vamorolone, this is from the first 24 weeks of the pivotal trial. Bone turnover markers, both formation on top and resorption on the bottom, just crashed on prednisone and were maintained or increased on vamorolone 2 and 6 milligram per kilogram. When the boys transitioned from prednisone to VAM2 in blue or VAM6 in red, there was an immediate reversal in the bone turnover decline that was initially experienced on prednisone. So the release of inhibition on vamorolone is immediate. It doesn't take time for those bone turnover markers to recover. And that's all 3 bone turnovers that were measured. And then this is looking out to 30 months, bone turnover markers on vamorolone 2 plus 6 milligram combined, and you can see that they are not declining significantly. So bone turnover is maintained on vamorolone. What about growth? Whenever you see bone turnover is better, you often think that that should go along with growth, and that's what we see. So we see that the height percentile declined on prednisone in the first 24 weeks, and it increased on VAM at 6 milligram per kilogram and was stable in terms of height percentile change on VAM 2 milligram per kilogram. Similar increases in BMI Z-score, though, on VAM 2 and 6 relative to prednisone. Now here's the mean change in height Z-score, looking at VAM2 and 6 in red compared to prednisone and deflazacort in variations of blue. And you can see the height just goes down on the left on classic steroids and goes up on vamorolone. And then on the right, you can see that with VAM2 and 6 combined, that over the longer term, 30 months, that increase in the height Z-score continues and just crashes on classic steroids. And this is the immediate reversal in height Z-score decline, transitioning from prednisone to VAM2 or VAM6. So like bone turnover markers, when they started VAM after being on prednisone, it was like the brake being lifted on height Z-score decline. And here we have the change in BMI Z-score. So it goes up on VAM2 and 6 and then seems to settle down beyond 24 weeks, whether VAM was on board continuously or transitioning from prednisone to vamorolone. And finally, vertebral fractures. So once again, we're looking at vamorolone compared to an external comparator, the vertebral fracture prevalence after 3 years on vamorolone relative to the 4 DMD cohort. We can see that the prevalence was similar for vertebral fractures on daily deflazacort and daily prednisone. There were no fractures observed after 3 years on intermittent prednisone, and the vertebral fracture prevalence was lower on daily vamorolone. And we have the suggestion here that the fracture phenotype is more severe on daily deflazacort. The SDI per patient on average was 0.82, on deflazacort, on daily prednisone 0.42, and then on vamorolone was the lowest at 0.21. So vamorolone did not appear to suppress bone turnover markers. It had a favorable impact on linear growth. It did not advance bone age, so that improved growth did not come at the expense of accelerated growth maturation at the growth plate. Vamorolone appeared to have a lower vertebral fracture burden compared with daily deflazacort and daily prednisone. And these results suggest vamorolone may be relatively bone sparing in ambulatory boys with Duchenne compared with classic steroids. And these observations merit further investigation over the longer term. And my last slide is just to say that as we go forward with new agents, potentially to treat Duchenne muscular dystrophy, we'll have to think about how we're going to monitor these boys. For the moment, if you have a boy on vamorolone, we recommend you do not give up monitoring their bone health. We don't have enough information to de-escalate that just at the moment. Continue your minimum standard of care approach and do regular spine x-rays and treat early signs of vertebral or long bone fractures. I'd like to thank my funding sources for this work, the CHEO Research Institute and Muscular Dystrophy Canada, the Foundation to Eradicate Duchenne, my team who just worked so hard in the background on all of these data. Just love every one of them working on this project with passion, and all of you around the world who are working hard to take care of boys with Duchenne muscular dystrophy. So thank you for your attention.